Hello. Sorry. Good morning, sir. Hello. Good morning, sir.
Good morning. Hello.
Sir, can you wait for some time, sir? Participants are still joining, sir.
No problem.
Few more minutes, sir.
You
Yes,
tell
sir.
me when you are ready.
Yes, sir. Thank you, sir.
You have to give me sharing option, I think, or I can share like that.
Yes, sir. Sir, we had made you co-host. Can you share and say, sir, whether your slides are coming or not? Sir? Dr. Vishnubhat, sir?
Yeah, I'll share now.
Yes, sir. Thank you, sir.
Are you able to see?
Yes, sir. We're able to see, sir.
It's not full screen, I think.
Not full screen, sir.
I'll put this slideshow. Now it's okay?
Yes, sir.
Okay. It's already screen. Till the date for that.
We are celebrating on 24th date. So that meeting for PG, the PG. We get coming from 10 minutes inaugural meeting.
And actually, I am out of station from 23rd to 25th.
Okay.
So you will be there.
Not
எனக்கு உங்க பெரிய மேடம் வராங்க.
Yes, sir.
நல்ல I'm going for a conference.
Okay, sir, no problem. Okay, sir. We will make the PG.
I have stopped sharing now.
Yes, sir.
Is there any issue?
Sir, we're just starting, sir.
There is another talk after 11. We have to finish.
Good morning, one and all. I'm Dr. Narani from on behalf of Department of Neonatology, AIIMS Bilaspur, Himachal Pradesh. I welcome you all for the CME Newborn Care. It's a scientific program for practicing physicians and postgraduate. I invite our Dean Academic Staff to the inaugural address. This auspicious occasion of National Newborn Week celebration is celebrated from 15th to 21st of November every year. Theme for this year is home-based care of newborn in urban area. Sir, please, can you kindly give us inaugural address?
Yeah, good morning, everyone. Nalini, I'm audible?
Yes, sir.
Yeah, good morning, everyone. Newborn Care Week is celebrated every year in the country from 15th to 21st of November. The aim of celebrating this week is to raise awareness about importance of newborn care for child survival and development. And the theme for this year is home care of newborn in urban areas. Because neonatal period, that is the first 28 days of life, are the crucial period for child survival, and because this period carries highest risk of death per day than any other period during the childhood. It is the period that lays the foundation for lifelong health and development, and healthy babies grow into healthy adults who can thrive and contribute to their communities and societies. Every year, 2.6 million newborn die, mostly in first week, and almost similar number are born still. Though neonatal mortality rates had declined, the goal of reducing under 5 mortality to less than 20 or less per thousand live births by the year 2035 can only be attained with specific efforts to reduce newborn mortality. Labor, birth, and immediate postnatal period are the most critical for newborn and maternal survival. About 75% of newborn deaths can be prevented with known effective health measures provided at birth and during the first week of life. Major causes of newborn deaths in India are prematurity in about 35%, neonatal infection in about 33%, and birth asphyxia in 20%, and other congenital malformation in about 9%. All newborns require essential newborn care to minimize the risk of illness and maximize their growth and development, prevent many newborn emergencies. Warmth, normal breathing, mother's milk, and prevention of infection are the basic needs of normal baby at birth. These basic needs indicate that the baby's survival is totally dependent upon her mother and other caregivers. Therefore, it is important to provide proper care to all neonates immediately after birth. Indian Newborn Action Plan, in response to the global Every Newborn Action Plan, aims to bring down neonatal mortality rate and stillborn to single digits by the year 2030 through existing reproductive, maternal, neonatal, child health, and adolescent programs. Other programs like MA, that is Mother's Absolute Affection, is a national program for promotion of breastfeeding through health systems, and Pradhan Mantri Surakshit Matritva Abhiyan is aimed to reduce maternal and infant mortality rates through safe pregnancies and safe deliveries. Healthy mother, healthy birth, and good health in first day of life equals good start of childhood. Thank you and Jai Hind.
Thank you so much, sir. Now I call upon Dr. Vishnudat sir, Director of Medical Research, Professor of Pediatrics and Neonatology. He is retired from JIPMAR as a Dean and Director. Presently, he is working in Arvada Medical College, Pondicherry. He has been from JIPMAR since his medical college period. UG from JIPMAR, PG from JIPMAR, senior residency from JIPMAR, obtained WHO fellowship maternal infant care from Nepal and Thailand. He has also obtained WHO fellowship neonatology training in University of Illinois, USA. He worked in JIPMAR as a lecturer. He joined as a lecturer, assistant professor, associate professor, associate professor, and HOD of pediatrics and neonatology. He worked as a dean research director, retired from JIPMAR in 2018. More than 40 years of experience in teaching pediatrics and neonatology since 1979. He has been a faculty of National Teachers Training Center since 1987. He has more than 380 publications, research papers, 58 book chapters, and edited 3 books. Associate editor of Indian Journal of Pediatrics. He is a reviewer of many national and international journals. He is the one who initiated DM Neonatology and PhD Neonatology program in JIPMAR. He has been honored with several awards for his work, including his Lifetime Achievement Awards by multiple organizations. His field of interest are medical education, perinatal asphyxia, genital sepsis, mental malformation, low birth weight, and preterm care. I invite Sir Dr. Vishnudat sir to give his presentations, essential newborn care.
Can you see the slides? Hello?
Yes, sir, we can see the slides, sir.
So can I start? I think this is the wrong one is coming here.
Yes, sir, this is I'm writing manuscript, sir.
Just 1 minute. ನಾವು invitation ಕೊಡ್ತಿದ್ದು photos. Is it okay now?
Yes, sir.
Okay. So at the outset, let me thank you, the administration of AIIMS Bilaspur and Dr. Nalini, who invited me to deliver this talk. I will be covering essential newborn care during the next maybe about 35 minutes. Already your dean has told the importance of celebrating newborn week, and it is from 15th to 21st of November every year. 7 days we are celebrating. It might have been kept from 15th to 21st because the Children's Day falls on 14th of November, and immediately to sensitize people for newborn care, it might have been selected 15th to 21st of November. The infant mortality, if you see in India, it's about 35.2 per thousand lives, which used to be more than 100 when I was a student. So it has been brought down almost by 1/3. The neonatal mortality is 24.9 per thousand lives, and our neonatal mortality accounts for almost 27% of the world's neonatal deaths. And you look at the exclusive breastfeeding is only 63.7%, and we advise breastfeeding during the first hour after birth. It is only 41.8%, which should be 100%. So we have a long way to go in reducing the neonatal mortality and improving exclusive breastfeeding and early initiation of breastfeeding. And if you look at the cause of neonatal mortality, which already Dean said, I am reinforcing that. The preterm and low birth weight accounts for the major chunk of neonatal mortality, which is about 35%. Pneumonia and sepsis, the infection, another 30% or 1/3. Birth asphyxia and birth-related problems like obstructed labor or cord prolapse, all these things will account for another 25%. So if you take care of these three major issues, management of preterm low birth weight, asepsis and prevention of infection, prevention of birth asphyxia, proper delivery, majority, almost 75% of neonatal deaths can be prevented. Congenital malformation accounts only for 9%, only 1% accounts for all other rare conditions and causes. And if you look at the time of neonatal death, almost 73% of them occur in the first week of life, and another 13.5% in the second week, and another 13.5% in third and fourth week. What I'm trying to say is that the major part of neonatal mortality occurs in the first week. So if you want to reduce the neonatal mortality, you should act immediately after birth or even before birth. Is my voice clear?
Yes, sir. Clear.
So, and the dean was also mentioning about essential newborn care. So we have to give care during the baby immediately after birth because survival is one of the most important thing. So we should train those who are conducting delivery in providing ventilation by bag and mask and cardiac compression to stimulate the heart if required. Immediate postnatal care is important because dry the baby, give warm and give breastfeeding. Breastfeeding is like immunization of a newborn or a child. It will prevent many diseases and also protect the baby against infection. Prevention hypothermia is one of the major issues, even in the warm climate conditions, because our body temperature is about 37 degrees. Only the environment temperature, except in hot summer, it will be lower. and many babies may develop hypothermia. So drying the baby, providing warmth are very important. As I already said, 1/3 of the neonatal deaths are due to infection. So prevention of infection is important, not giving antibiotics, treating infection. That is the later part of treatment, which may not be that effective. So our aim should be to prevent infection as much as possible and treat those infants or newborns who have developed infection in spite of our preventive measures. To this, we add now to neonatal screening for hypothyroidism, screening for congenital dislocation of the hip, screening for congenital adrenal hyperplasia. So the neonatal screening is important. In addition to that, all major and minor congenital malformation to be looked for. So immediately after the baby, after the resuscitation, giving warmth, they should also be screened for major issues which may require immediate treatment. If hypothyroidism is diagnosed and supplementation is given, you can prevent brain damage or developmental delay because of hypothyroidism. It's very important that we give education to the parents, because parents' education is one of the most important thing. They are the primary care givers at home. So they should know what are the normal care to be given, and also when they should visit the hospital if the baby becomes sick. It's always better you make a pre-discharge checklist so you do not forget or you do not miss something which need to be attended to. So always have a checklist, or you have a discharge slip with advice to be given, which will be given for all newborns. But if there is any special issue, they need to be given special instructions. We should also guide and train the paramedicals as well as the parents in identifying a sick neonates when you should consider taking the infant to the hospital. So care during research or immediately after birth, you should wash your hand properly. You should provide a clean environment and warmth after delivery. Now the present recommendation is cut the umbilical cord after 1 minute. This 1 minute is taken because by 1 minute, more than 90% of the blood which will be coming to the baby will be transferred by that time. So you wait for 1 minute. Unless the baby is very sick and needs immediate resuscitation, and a cord clamp has to be put, otherwise bleeding may occur. If it slips or if it is not put properly, the newborn may lose blood and can be dangerous. So before the baby is born, you have to keep everything ready. You should have a laryngoscope, endotracheal tube, drugs, and open care system which is ready to receive the baby. You should have a pulse oximeter. So all equipments and medication which are needed for resuscitation should be available at the time of delivery. One should not run around for searching for items after delivery of the baby. So every person who is involved with the delivery should be prepared for receiving a baby and resuscitate the baby if required. Not all babies will require resuscitation. More than 90% of the babies will be active, breathing on their own. They will require only supportive care. They do not require resuscitation. Only about 10% of the babies will require about some type of resuscitation, and only less than 1% or 1% will require serious resuscitation. So once the baby is born, you should look whether the baby is breathing and crying, whether it looks almost normal. If that is the case, then routine care is given. If the baby is term and breathing and crying, it should be given routine care, put on the mother's abdomen or chest, dry the baby, suction if required. Not all babies need to be suctioned after delivery. If necessary, you do suction, cut the cord after 1 minute, check for breathing and color, initiate breastfeeding. This is called routine care. So most of the babies will come under this group. If they are doing well, there is no problem. You will give routine care. But if the baby is not breathing, gasping, or not doing well, you should cut the cord immediately. Place the baby under a warmer, not on the mother's abdomen. Open the airway, suction, dry and stimulate, and reposition for better breathing. So, if the baby is breathing, we'll go for routine care. Otherwise, we will start initiation of resuscitating the baby. If the baby is gasping or is apneic, he will require bag and mask ventilation. Nowadays, we do not recommend mouth breathing because you may get infected from the biological material, or you have infection, you may infect the baby. So it is better to use a bag and mask. The pressure will be controlled, volume will be controlled, and you can resuscitate the baby better, or a TB resuscitator can be used. But if the baby continues to have problem like cyanosis or not breathing well, you open the airway, you monitor the SpO2, the oxygen saturation, consider CPAP and give oxygen if required. So you have to evaluate the baby after every 5 to 6 inflation of your bag and see whether the baby is improving or not. So the positive pressure ventilation is one of the most important thing. And if the baby recovers, there is no breathing difficulty, heart rate is more than 100 and general condition good, then again it can go for observation care because you have given resuscitation. So if the baby's heart rate is more than 60 to 100, he can continue with bag and mask ventilation. But if it is less than 60 per minute, in spite of your bag and mask ventilation, he will require cardiac compression. Suppose you are not improving the cardiac compression, heart rate is still low, you give adrenaline or epinephrine. You get 1 in 1000 adrenaline, you have to dilute 10 times to make it 1 in 10,000, then you give 1 ml per kg. And some babies might have lost blood, especially if there is an antepartum hemorrhage or cord flap might have loosened, then you have to give volume expander. Do not expect the baby after birth to have 90-95% oxygen. Normally, in a normal baby, the first minute, the saturation will be only 60 to 65%, which is the saturation which the fetus was having inside the uterus. And gradually it increases as the baby starts breathing. 2 minutes, it will be 65 to 70%. And every 5 minutes, if you see, it keeps increasing by 5 minutes. And only at 10 minutes, a normal newborn will have 85 to 90% saturation. This you must understand. If you give too much oxygen to a newborn, it can create problem, what's called oxygen toxicity. Now coming to the immediate newborn care, after drying and providing warm, breastfeeding is very important. We have to check the baby's weight because further care will be depending upon the gestation and weight also after resuscitation. If the baby is born preterm or very low birth, it may require special care. And carefully, you have to screen for malformation because some of the malformation may be major, which will require immediate care, like a child with tracheoesophageal fistula, diaphragmatic hernia, or example or open neural tube defect, which will require immediate attention. So you should look for major malformation. You should also look for minor malformation once the baby is stabilized. You have to give eye care and cord care and skin care for the baby. Skin care is very important in the baby preterm. Earlier, we used to remove all one cases, but now we say that it is a protective to the newborn. So do not remove all the vernix from the body, only dry the liquid and cover the baby. Eye care is important. Take cotton, wet it in sterile saline, clean from medial to lateral. And cord also should be cleaned and allowed to dry. Do not put anything on the cord, and skin should be protected, especially if a preterm baby. We give oral polio vaccination. We give hepatitis B and also BCG vaccination. And all newborns after delivery should receive vitamin K because very important. It will prevent hemorrhagic disease of the newborn. You give 1 milligram of vitamin K for a term baby, half a milligram for a preterm baby. Another important thing is breastfeeding. As I told in the beginning, breastfeeding is highly protective. It will give the best nutrition. It is best of everything. Positioning of the mother is important. If the mother is all right, you make her give a semi-reclining position with the back support, keep the baby head up and position properly for feeding so he is comfortable. And the latching should be correct because the low up part of the areola should not be seen. The chin of the baby should be touching the breast, widely open mouth covering the areola completely, and baby should be made to suck. If the baby has not latched properly, it can cause pain and discomfort to the mother. If repeatedly it sucks, the baby mother may get nipple sore nipple, and also milk output will not be good. So latching is very, very important. The nurse or the doctor or the health worker should support the mother for proper breastfeeding because the parents and attender may not be very clear what need to be done, and all issues related to breastfeeding should be clear. Ideally, training of the mother should be done during the antenatal period so that she will have no confusion after delivery of the baby. Sometimes, if you start advising after delivery, mother may not be in a receptive mode at that moment because she has to take care of herself also. So it is better you give proper advice, nipple examination during antenatal period. Prevention of hypothermia is very important. As I said, the normal temperature of the newborn should be maintained. And if the baby is not dried and covered, every 1 minute, the baby will lose temperature of 1 degree centigrade. And 1 degree centigrade is equivalent to about 100 kilocalories of energy. So you have to take care of that. And there should be a warm change, whether the baby is in a delivery room, whether it's in a transport system, during the transport from delivery room to the ward or in the postnatal ward. The warm chain should be. Cold chain is for vaccination, warm chain for the newborn. So that both are important, warm chain and cold chain. So in the delivery room, what we do is we maintain the temperature around 26 to 28 degrees centigrade. So it will be comfortable to the people who are working as well as the mother. And we dry the baby and give warm cloth and kangaroo care of skin to skin contact. Keep the baby on the mother's chest between her breast. So the baby requires gets not only warmth but also breastfeeding as when he is hungry. During transport, you can use warm cloth. You can also use face changing materials. Face changing material matrix can be set at different temperature. It is used for cooling in hypoxia babies, but also can be used for heating if the melting point is changed. So this material can have different melting point. It can be used for heating as well as cooling. Depending upon, not the same mattress can be used for both. They are different. And you can use, hello, you can use incubator, you can use skin to skin contact or kangaroo care. In the postnatal ward, you need to provide warm room, adequate clothing, and rooming in, and delay the bath. Do not give bath during 24 hours, or if most of the babies do not require bath before going to a home, they can take their baby's bath at home, not in the hospital, because The risk of infection is more if you give birth to the newborn in the hospital, because so many babies will be there one after another you give, and many people will handle, will cause more infection. So prevention of infection is the next important thing. One of the most important thing in prevention of infection is hand washing. So proper hand washing is very, very important. So you all must be knowing the 6 steps in hand washing. You put wet water your hands, put soap, then put the back side of the hand, the knuckles, the front side of the hand, thumb, then wash. So it should be properly followed, the steps of hand washing. Many neonatal units may not have washing facility, or people may not follow the proper washing advice. It should be taken care. You give cord care, you give clean clothes to the baby, so it should be sterile so that it does not carry infection. And whatever you comes in contact with the baby should be clean and sterile, and the surroundings should be good, and exclusive breastfeeding should be given. Now coming to the neonatal screening, you need to look for congenital malformation. So look for all abnormalities, whether it's minor, major, whatever it is, you record. Major malformation is one which will need to be treated for providing proper life, and also cosmetic disfigurement. If it is there, then you call it a major. You need to do pulse oximeter during resuscitation and later. Later, it helps you in diagnosing congenital heart disease if the baby is breathing well. You should also monitor the baby for jaundice before discharging and at follow-up. Congenital dislocation of hip should be screened. You should always look at the red eye reflex of the baby, because the newborn may have congenital cataract. And majority of the congenital hearing loss are not detected unless you screen the baby. So every newborn should have a hearing screen before he goes home. And some laboratory tests, as I said, hypothyroidism and congenital adrenal hyperplasia screening, all those should be done. Now, pulse oximeter, when you take the reading, it should be in the right wrist while screening. You also put on the foot ankle, because you can also look at the upper limb, lower limb difference. If it is in a coactation of aorta, the lower limb saturation will be lowered. So, and also PDA will be changed. So you need to screen the baby with pulse oximeter. Better to do after 24, 48 hours after the resuscitation. Later you do, before you discharge the baby. Many congenital malformations, congenital heart disease may be diagnosed by doing a simple pulse oximeter. If there are problems, like if the saturation is less than 90% or upper limb, lower limb difference is more than 2%, then he need to be evaluated. The baby has to be evaluated. So if by supportive care, if there is suppose a baby is breathing some problem, obviously the saturation will fall. But many of this congenital heart disease, breathing will be normal. In spite of that, the baby's saturation will be low. So any baby, the saturation is less than 90%, or difference between upper limb, lower limb is more than 2%, they need to be screened for congenital heart disease. Am I going very fast? Is it okay?
It's okay, sir.
Okay. Now, another important thing, what I was telling is a jaundice. For bilirubin, you need to take the blood if you want to serum bilirubin. But this equipment, what's called as a transcutaneous bilirubin emitter, this is good for screening. So you put it on the forehead or the sternum, because the subcutaneous tissue should be minimal when you put there. So you just press, you will get the reading. So it gives a initial screening, because when you look at the baby's jaundice in clinically with your own eyes, the light should be very bright and normal light should be there. Then only you can pick up milder jaundice. But this machine, whether it's put in the dark room or lighted room, it will give the same reading because it depends on the skin color. And you mark the jaundice, the date, hours of life of the baby and the bilirubin. Whether you do a transcutaneous bilirubin or a serum bilirubin, you mark on this chart. This is called Bhutanese curve. So depending upon the level, you can look where it falls. If a baby falls on the high risk area, then it will require monitoring of serum bilirubin also, because high bilirubin can cause brain damage. So you should prevent hyperbilirubinemia and treat if the baby develops hyperbilirubinemia. Congenital dislocation, if not diagnosed, it may require surgery later, so it should be diagnosed and treated after birth. This is what's called as a orthogonalist test. You hold the newborn's knee joint with your palm, put the thumb in the middle side and other fingers on the greater trochanter. Then either it do abduction or adduction. If do abduction is called orthogonalist test. So this head has gone outside the acetabulum, it will come inside. Whereas it is not dislocated yet, you do the adduction. In a dislocatable case, the head will go outside of the acetabulum. Red eye reflex, this I was telling you that you just take an ophthalmoscope and look at the baby's eyes. Normally, you should get a red reflex from the retina. If it is not there, either the baby is very preterm, which will have opacity of the anterior pupillary membrane, whereas normal babies should have a red reflex. If it is not there, it means the baby is having opacity, congenital cataract. Whatever is the cause, it requires to be treated. Hearing screening. If you take all deaf children, almost 50% will not have any risk factor. So if you wait for risk factor, 50% of the hearing loss you will miss. And early diagnose your hearing loss very important, because if you give hearing aid, they can develop normal speech. So it is important that before 6 months, before the child starts vocalizing, the hearing loss should be detected and you should give support to the newborn. Look for congenital malformation from head to toe. This is hydrocephalus, microcephaly, anencephaly, encephalocele, like that, cleft palate, exomphalus, abnormalities of the genitalia, extra fingers, no finger, all these things have to be recorded. This is very important because the major malformation may require treatment after, but some can wait, of course. Screening for hypothyroidism. Earlier we used to collect blood sample, that now this filter paper technique has come. So you can prick the heel and collect the sample in the filter paper and sent to the lab. You can get screening done for hypothyroidism as well as congenital adrenal hyperplasia. If the baby has got hypothyroidism, it should be treated immediately within the first 2-3 days, so that the baby will not develop complication of hypothyroidism. Most important is developmental delay. Congenital congenital adrenal hyperplasia may have some abnormality of the genital organs, but you should diagnose and treat. Otherwise, usually by 1 week, they will come with severe dehydration, acidosis. Coming in a very sick stage, we may lose some of the babies. Parents' education is very, very important, as I already said, because they are the first people who will be monitoring the newborn. So pre-lactal feed should not be given to the newborn. Many places they may give honey, or they may give coffee, tea, whatever get in their hand, they may give to the baby before breastfeeding human, which should never be done. Cow's milk, donkey's milk, some places they may give. Vigorous massage should be discouraged, should not be given. But putting oil on giving gentle massage is fine. But if you vigorously do, you may cause dislocation of the joints or may cause even fracture. No oil should be instilled in the nostrils or ears of the baby because oil aspiration can cause lipoid pneumonia and other problems. This is practice in Tamil Nadu and some of the areas where they used to put oil in nose. Now we tell them do not use all this. And application of cow dung or any other material on the cord should be told not to do because they can cause infection and tetanus. Of course, antenatal tetanus toxoid to the mother has reduced the occurrence of neonatal tetanus to a large extent, but even if not tetanus, other infection can get inside. So you should not apply anything to the umbilical cord, only clean its spirit and allow it to dry. And kajal, many people apply to make the baby look beautiful. Beauty can be developed, beautification can be done later. If you put early life, it can cause reaction in the eyes and conjunctivitis. Some common ailments during newborn like vomiting. So many parents will say, my baby is vomiting. But many times it is regurgitation, not vomiting. So you should actually ask them to show what actually they are meaning vomiting. If the baby is fed in lying down position, not buffed properly, regurgitation can occur. But large vomiting should be a matter of concern. We should look for a problem. If the vomiting is large, continuous, and has blood or meconium, then it is abnormal. It may indicate some obstruction in the GI tract. As you know, the newborn initially will pass the meconium, then it will start more frequent stools, what is called as a transition stool, which is more yellowish in color, frequent, watery. It is normal in the newborn. But if it contains blood and mucus, it is abnormal along with vomiting or abdominal distress. So you should be careful. What is normal, what is abnormal, you should be able to judge. And physiological jaundice occurs in a large percent of newborns. Almost 65% of the term babies, 75% of preterm babies will have jaundice. The jaundice appears on the second day and reaches the maximum by fourth or fifth day, and by 10 to 14 days they will disappear. If the jaundice involves the extremities, palms and soles, it is very high level of bilirubin and you should be very, very careful. It may require an exchange transfusion. Crying is normal as well as abnormal. So newborn cannot tell us, I am hungry, my napkin is wet. It cannot tell. So it will cry whatever is the problem. Even if you don't attend to a newborn, he gets isolated, then also it will cry. But continuous and shrill cry is abnormal. So one should be able to differentiate what is normal and what is abnormal. And some evening colic is normal. The newborn requires more soothing, but sometimes may create problem. Breath holding spell also could be normal. Newborn does not breathe like us. It breathes for some time, stops. It breathes, it stops. That's called periodic breathing, which is normal. Excessive sleeping also could be dangerous. So, but normally, most of the time, the newborn will be sleeping, except the time when he is voiding and drinking milk. So, whether it is normal range or not, it should be checked. Mastoid neonatal is the engorgement of the breast. This is because of hormonal effect. Should not be squeezed. If you squeeze, it will cause infection. There could be some vaginal secretion and vaginal bleeding after birth during 3 to 5 days, which is because once again, because of withdrawal of hormones. Transient sunsetting is normal, but continuously if it is there, it is abnormal. It will indicate convulsion. And sometimes the nasolacrimal duct may be blocked and may cause problems. So it should be required gentle massaging. After the umbilicus falls, there could be a granuloma which may require cauterization. And if you look at the head, sometimes there may be what's called as a caput, which is involving all the head or one part of the side of the head, which is called cephalometom. Caput is due to pressure on the ascending part, whereas cephalometoma also is due to pressure, but there is bleeding under the periosteum. It may cause hyperbilirubinemia, but both do not require treatment. You need to observe them. Pre-discharge checklist, as I said, is important. Look for malformation, screen for problems, vaccinate, specific instruction you should go, and also tell the parents when to bring, how to come for follow-up, especially the babies preterm or low birth weight require regular follow-up, or if it has got hypoxia or some other problem. So you should have a checklist, all points like whether the baby has passed urine and stools, whether the weight loss is within normal range. Normally, if you see a newborn, within the first few days, there will be weight loss. Maximum weight loss in a term baby will be on the third day, whereas in the preterm, it may be 7 days or later. So after that, a term baby will, by 7 to 10 days, will come back to the original weight, whereas preterm will take longer time. And you should look for red reflex, cleft palate becoming weird problem, whether genetics is normal. All these things have to be checked and recorded. And as I said, all newborns should receive oral polio vaccine, BCG vaccine, hepatitis B vaccine. They should be given before you discharge the baby. And you should give proper advice so that mother knows not only the danger sign, but also knows when to come back to check up. Identification of sick newborns very important. If the jaundice involves the palms and soles, if there is central cyanosis, if there are abnormal movements in the body, sometimes the jitteriness may get confused. Convulsion, when there is convulsion, people may not recognize. I will not go into the details because I think there is a talk on that issue. And sometimes the baby will be lethargic, or if there is respiratory distress, abdominal distension. Both fever as well as hypothermia, low temperature, high temperature, both are abnormal. A term baby develops fever when there is infection, whereas a preterm sick baby may develop hypothermia. If there is a persisting vomiting or blood and meconium stained vomiting, it is abnormal, will require immediate care. If the baby is feeding well, there are no danger signs, mother is confident of taking care of the baby, you are given proper advice, and baby is otherwise okay. And normal baby will regain 15 to 20 grams in a day. And their proper feeding, proper gaining weight, no issues, baby can be discharged from the hospital. So to conclude my talk, simple, cost-effective intervention can save many lives, and we should concentrate on that. It is cost-effective and effect may be very large. And principles of neonatal care include breastfeeding, maintaining warm chain, prevention of infection, identification of high-risk neonate, education of parents will go a long way in reducing neonatal mortality and morbidity. So educating and preparing the parents and healthcare workers is the very important intervention which you should do. And you should tell the parents what is physiological changes in the newborn period and what are the problems for which they can need to come to the hospital, which can be dangerous, should be told. So thank you very much for your kind hearing. And if there is any doubts, clarification, please ask. I am available. I don't know how much time I am left or I have exceeded the time. Can I stop sharing the slides?
Yes, sir. Thank you so much, sir.
Yeah.
For that excellent presentation. Basics are always very, very important because these basics with low-cost interventions only are going to save majority of the newborns. Very few newborns will be going to require ICU care, not key care, but majority of newborns require these low-cost intervention, and prevention is always better than cure. So, sir has reiterated that how we can prevent hypothermia, hand hygiene, prevent infections, keep the baby warm, and breastfeeding. These are all normal phenomena. We should continue. Thank you so much, sir. And any doubts, because I have to go for another meeting. So we can ask questions, sir, now itself. Sir, do you have any time to spare? Or?
Yeah, I can be, if there are questions, definitely I will answer and then go for to the next meeting. We are continuously doing meeting from morning till evening.
Thank you, sir.
Anyone?
Anybody has any doubt? Very clear. Sir has explained to you very clearly so that you are not having any doubts. Thank you so much, sir.
Thank you. Thank you very much. So shall I mute then?
Yes, sir.
Okay, thank you.
Now I call upon Dr. Manju. She is assistant professor of dermatology in AIIMS Bilaspur, Himachal Pradesh. And she is going to talk about physiological changes, skin changes in newborn. She has completed her UG from RPGMC Canada, PG from PGMC Chandigarh. She is a gold medalist from school age itself, and she has been bagged many awards. And she has more than 30 publications in reputed journals, 4 book chapters. She is reviewer of many reputed journals, and she is also a member of many societies. Her areas of interest are clinical dermatology, psychology, and vitamin D. I call upon Dr. Manju ma'am, kindly take over for physiological skin changes of newborn.
Thank you, Dr. Nalini. Am I audible?
Yes, ma'am, you are audible.
Good morning, all. I am humbled and thankful to the organizing team for inviting me today. And I'll speak on the topic physiological skin conditions in newborn. Yes. So starting with the introduction, neonatal skin is unique in the way that it has a very immature defense mechanism. So it is very vulnerable to chemical, irritants, and microbial attacks. There is increased body surface area to weight ratio. So there is increased absorption of the topical medications applied. The skin barrier is very much immature, due to which there is more transepidermal water loss. There is risk of dehydration. And then the intrauterine exposure, if there is an intrauterine infection, then the neonate is already exposed and there is more chance of more chance of infections. So the physiological skin conditions, they are very common in newborns. They are very minor evanescent lesions, but when florid, they may cause undue concern. They are benign and transient and they do not require any therapies. These are the common physiological conditions we come across commonly. First one is the vernix caseosa. It is present at birth. The skin is covered with a whitish greasy film, the vernix caseosa, and the vernix may cover the entire skin surface, or it may be present only in the body folds like in groins or in the neck area. And this acts as a naturally occurring barrier cream which also contains antimicrobial peptides. It is useful for thermal regulation and it is a known antioxidant too. It is formed of fetal periderm and sebaceous secretions. Then is the acrocyanosis. It is seen in full-term newborns, usually particularly marked on the palms and soles and around the mouth. And the physiology behind it is the vasospasm of small vessels of skin in response to cold. And it is regarded as normal during the first 48 hours. And it improves by warming the baby. Then is the physiological hypertrichosis lanugosa. It is seen in preterm infants. The hair, they are normally shed in utero about 1 month before term. And they are replaced by a second coat of shorter lanugo hair, which is present at birth in full-term infants. This is a superficial cutaneous desquamation. It is also known as physiological desquamation of the newborn, and it occurs in normal full-term neonates. It tends always to be more severe in neonates who are small for dates. And then is the miniature puberty. In the newborn female, the genitalia, it appears succulent and the size of the clitoris is large. Mucoid vaginal discharge may be seen. Frank withdrawal bleeding may occur. And in both sexes, hypertrophy of the mammary glands may occur. And in 2 to 3 days, discharge of milk from the breast may be seen, which is known as witch's milk. This is the harlequin color change. It's seen in 15% of the neonates, and this phenomena occurs when the baby is lying on one side. The upper half of the body it becomes pale, and the lower half gains a deep red color with a sharp midline demarcation between the two. And the duration of this attack is highly variable. It may last from half a minute to 20 minutes. It reflects the immaturity of the hypothalamic centers, which are responsible for the control of peripheral vascular tone. This is the cutis marmorata. Normal neonates, they may demonstrate this faint marbled-like appearance even in normal environmental conditions. This reticulate blue-red vascular pattern, this is accentuated physiological vasomotor response to cold, and it is very temporary, but if it's persisting these conditions, it may persist. Telogen effluvium of the newborn. The roots in the occipital area of the scalp, they enter the telogen during term. So conspicuous alopecia may be present at this site around birth or within the first 2 months, and it is known as neonatal occipital alopecia. Then is the sebaceous hyperplasia. It is very common condition seen in around 50% of normal neonates. There's multiple uniform pinpoint yellowish papules. They are prominent in the nose and cheeks area, and it reflects the influence of maternal androgens, and they get resolved itself by 3 to 4 weeks. Then milia and the Epstein pearls. These milia are the benign keratinous cysts, which are 1 to 3 millimeter in size, white globular papules, and occurring at the same sites as sebaceous hyperplasia, and they tend to disappear spontaneously. Then are the Epstein pearls. These are commonly, Epstein pearls are 1 to 2 millimeter pinpoint whitish keratinous cysts and seen at the junction of hard palate and soft palate or along the alveolar ridges. Then are the Mongolian spots. They represent the dermal melanocytes. There is entrapment of melanocytes in the dermis of the developing embryo, and cells fail to reach their location in the epidermis. So these blue-gray, poorly circumscribed single or multiple patches of various sizes may be present and commonly seen on the lumbosacral area, and they fade in first 2 years of life. Then is the salmon patch. They occur commonly in the glabular area or the nuchal area, and they are also very common. They are irregular, dull pink-red color macules with poorly defined borders, and they become intense in color when baby cries, and they spontaneously disappear by 1 year of age. Then is the sucking blister. This results as a result of intrauterine sucking of own skin by neonate. It is usually solitary and intact. Sometimes intact blister may be seen, or erosions or drying up crusts on a non-inflamed skin. They heal spontaneously, nothing active has to be done. Then are the neonatal acne. They are also quite common, seen in 20% of newborns. They are hormonally mediated. They may be present at birth or may be seen shortly after birth. They are the erythematous papulopustular lesions along with comedones at the sites where acne are commonly seen over the cheeks and nose, and gentle cleansers are the only thing which are required, and they resolve spontaneously. Then is the similar condition, neonatal cephalic pustulosis, clinically similar to acne, seen in first 3 weeks of life, but the implicated organism is Malassezia. And to differentiate, there is absence of comedones, and there is presence of erythematous halo around the papulopustular lesions. This condition is also self-limiting, but 2% ketoconazole cream may help if the lesions they persist longer or they are more widespread. Then there are few transient vesiculopustular conditions. They are also quite common in the newborns. First is the toxic erythema of newborn. It is a benign self-limiting condition of unknown etiology seen in 50% of full-term infants. The onset is first 48 hours after birth. They are usually not present at birth and may occur at any time until about the 4th day. Sites, anterior trunk is commonly involved and also present in the face and proximal part of the limbs. And palms and soles are spared. Clinically, the milder form presents with blotchy macular erythema, which fade within a day, or in severe forms, the papules and articular plaques may be present, which also spontaneously resolves in few days, and recurrences may occur, and no treatment is required in this. When smear diagnosis is mostly clinical, but when the smears are made, the inflammatory cells on Giemsa stain are more eosinophils, more than 90% of eosinophils are there, and blood eosinophilia may be present along with this. Then a similar condition, transient pustular melanosis. This is also idiopathic pustular eruption, and it heals with brown pigmented macules. And this is present invariably at birth only. Sites, any sites may be involved, but the chin, neck, forehead, back, and buttocks are commonly involved. 1 to 3 millimeter flaccid, superficial, fragile pustules with no surrounding erythema are there, which is followed by a pigmented macule. These pustules rupture and form a collarette of scales, and pigmentation may persist for around 2-3 months. The smear in this condition, it contains neutrophils, bacterial culture is negative, and condition is self-resolving. So to differentiate both of ETN and transient neonatal pustular melanosis, age of onset ETN after 24 hours of birth and TNMP at birth, they are present. The inflammatory lesions in ETN, while no surrounding in erythema in TNMP. The sides, back, buttocks are involved, and relative sparing of palms and soles, while in TNMP, palms and soles may also be involved. There is no residual pigmentation in ETN, while hyperpigmented macule is characteristic in TNMP. And on Giemsa staining of the pustule, ETN contains eosinophils, while TNMP, it contains neutrophils. Then a very common condition, miliaria. It occurs due to blockage of the eccrine ducts, and it's quite common, occurring 3 to 8% of neonates due to immature sweat ducts, occlusive clothings, and high heat and humidity. When there is obstruction of the sweat duct within the stratum corneum only, this crystal-like miliaria crystallina occurs. And when the obstruction is somewhat deeper, miliaria rubra, some erythematous papillary lesions occur, and sometimes these lesions may become pustular, known as miliaria pustulosa, presenting as crops of clear, thin walled superficial vesicles 1 to 2 millimeter in diameter, and no associated erythema is seen. They rupture by 24 hours, and bran-like desquamation is seen post-rupturing. And common sites are forehead, scalp, neck, and upper trunk. So treatment is light clothing and avoidance of heavy blankets and hot and humid environment around the neonate. This is the infantile acropustulosis, an uncommon condition of unknown etiology. There is recurrent crops of intensely itchy pustules on the palms and soles. And they occur in crops, and each crop lasts 7 to 14 days, and topical corticosteroids may be required if the lesions are very itchy. Eosinophilic pustular dermatosis, the lesions predominantly occurring on the scalp, which are mildly pruritic, 1 to 3 millimeter diameter pustules on the erythematous base with prominent secondary crusting, and occurring in the cyclic patterns. And smear contains plentiful eosinophils, and blood eosinophilia may be present in this. Thank you.
Thank you so much, ma'am. Most of the manifestations of the external organ is through the skin only. So we get panicked. Most of the mothers also get panicked seeing the appearance of these lesions. You had told us which are the lesions that makes reassurance. And now I call upon Dr. Payal.
My screen visible, Nalini?
No, ma'am, you're still you're waiting. So, Dr. Payal ma'am is assistant professor in Department of Dermatology, and she has completed her UG from NC Delhi and PG from PGI Chandigarh. She has completed her DNB, MNAMS, Senior Residency from AIIMS Rishikesh. She has done her observership in dermatopathology under Dr. U. Kotkar K. Mumbai, and she has worked as assistant professor in Himalayan Hospital, Dehradun. She has more than 65 publications in reputed national and international journals. She has been invited as a guest speaker for many forums on dermatoscopy. Her field of interest is dermatoscopy. So I call upon Dr. Payal ma'am to talk about the pathological skin changes in newborn, where we should be worried about it. Ma'am, please.
Thank you so much, Dr. Nandini. Can I share my screen? I think.
Yes, ma'am.
Can you see my screen?
Yes, ma'am. You can see your screen.
You can? You can see my screen?
Yes, ma'am.
Okay. So at the outset, I would like to thank Dr. Nandini, Dean Sir, and the entire organizing team for making me part of this neonatal week. So the topic for the presentation is common pathological skin disorders of newborn. So there are a number of pathological conditions that can involve a newborn. The list seems to be exhaustive. So I'll be talking about them briefly. And there can be infections, there can be disorders of subcutaneous fat, there can be disorders which happen due to transplacental transfer of antibodies, congenital ichthyosiform erythrodermas, inherited disorders, and certain eczematous disorders. So, starting with the commonest pathological conditions that involve newborn, that are infections. There can be bacterial, viral, treponemal, and fungal infections that can involve newborn. So, bacterial infection, the commonest is bullous and non-bullous impetigo. Herein, the neonate presents with these flaccid vesicles or bullae, which are present on an erythematous base. They rupture, they leave behind a peeling scale, and there is a moist erosion present. The common sites involved are the diaper area and folds of skin and the exposed areas. So the good thing about these infection is that they heal without scarring, and they're caused by staphylococcal aureus and beta hemolytic strep, and gram stain tends to show neutrophils and gram positive cocci. So the infection needs to be treated early, it needs to be recognized and treated early, and they can be treated with a topical antibiotic like mupirocin or fusidic acid, and when the lesions are more widespread, they require systemic antibiotics. So this is a neonate who presented with these lesions, and this is a case of non-bullous impetigo contagiosa. And after 3 days, we can see these honey color crust, which are characteristic of impetigo, and they heal without scarring. So a more severe infection that one needs to look out for is staphylococcal scalded skin syndrome, which is because of the epidermolytic toxin produced by Staph aureus. And this toxin, it circulates from a distant focus of infection. It presents within few hours of birth. The neonates tend to have a greater incidence of this because they have decreased renal excretion of the toxin. The child presents with prodrome of symptoms like lethargy, fever, irritability, and these lesions are extremely tender. The child has these diffuse erythematous sandpaper-like rash with flaccid or ill-defined bullae, and there is exfoliation of skin. We can see that this rash is more over the perioral and flexural sites, and it is peeling off. This is Nikolsky sign being positive. So when you apply gentle pressure, tangential pressure over the skin peels off from the underlying skin. It needs to be treated aggressively and early. So moving on to congenital syphilis, this is again, though uncommon, but a dreaded infection. And the neonate presents with rhinitis, which is snuffles, and it is seen within 1 to 2 weeks before the onset of rash. The cutaneous rash presents as diffuse papilloscomous eruption, and palms and soles can be involved. When palms and soles show vesicobilous lesions, that is highly diagnostic of congenital syphilis. Condyloma lata, mucus patches can also be seen. Systemic involvement in the form of jaundice, hepatosplenomegaly, and osteochondritis can be seen. The investigations that need to be done are maternal and neonatal blood samples for RPR and VDRL, neonatal blood count to look for thrombocytopenia, and CSF VDRL test. Dark field microscopy when shows Treponema pallidum is diagnostic. And treatment is indicated in cases where the neonate has a 4 times higher RPR values than the mother at delivery, when the neonate is born to a mother with clinical evidence of syphilis, or born to a mother whose VDRL levels did not drop fold or was rising after treatment. And the treatment is aqueous crystalline penicillin, 1 to 1.5 lakh units per kg per day intravenously for 10 days. Moving on to viral infections, neonatal herpes simplex. It is acquired during delivery or in utero, and there are 3 clinical patterns. One pattern is in which there is involvement of skin, eyes, and mucosa. The other is the CNS involvement, and the third one is the disseminated involvement, which is the most severe. The lesions tend to occur between day 2 and 20th of the newborn period, and they're isolated group vesicles, as we can see over here, and they can form generalized bullae and erosions. Oral ulcers can also be seen. Scalp and face are the most common sites involved in a vertex delivery, whereas perianal area in breech presentation is involved commonly. Systemic involvement in the form of jaundice, sepsis, pneumonitis, thrombocytopenia is dreaded. And the neonate needs to be treated with intravenous acyclovir as soon as the diagnosis is made. The next is neonatal varicella. It tends to occur between 10 to 12 days of life, and it develops when the maternal varicella has occurred within 5 days before or 2 days after delivery. There are generalized vesicles over an erythematous base. The systemic findings like pneumonia, hepatitis, meningoencephalitis can be seen in disseminated cases. The diagnosis is made through PCR, where viral DNA can be found, and treatment again needs to be aggressive in the form of IV acyclovir 20 mg per kg 8 hourly for 5 to 7 days. Another viral infection is congenital rubella. In congenital rubella, cutaneous lesions are among the commonest clinical features, and these lesions are typically present at birth or within 48 hours. They comprise of these discrete, round, red to purple infiltrated macules, and these appear purpuric because of dermal erythropoiesis. This is also known as blueberry muffin syndrome. Moving on to fungal infections, the fungal infections can be either congenital candidiasis or neonatal candidiasis. There are a few pointers that help differentiate the two. Congenital candidiasis is acquired in utero due to the ascending infection, and it presents at birth or within the first 12 hours of life, whereas neonatal candidiasis occurs when the baby passes through the infected birth canal or during postnatal period, and it presents after first week of life. In congenital candidiasis, we see a generalized eruption where there are erythematous macules and vesicles which form pustules, and these desquamate after the acute phase and they leave behind exfoliated crusted lesions. In this, oral and diaper area is not involved, whereas in neonatal candidiasis, there are erythematous patches with few scattered satellite pustules with peripheral scaling, and oral area and diaper area tends to be involved, but there are no constitutional symptoms. So this is a neonate with congenital candidiasis. We can see a diffuse rash, whereas in neonatal candidiasis, we can see the diaper area is involved, and these are the satellite pustules at the periphery. This Dr. Manju has already discussed, Malassezia pustulosis. The other disorder, pathological condition is scabies, which we all read about. It's one of the dermatological conditions that everyone knows, and it's caused by Sarcoptes scabies var humanus. It has a very generalized distribution in neonates. So when compared with adults, scabies in neonatal period tends to be present diffusely. The lesions are present diffusely. They can involve face, scalp, intertrigo, palms, and soles. So in adults, face and scalp are generally spared, but in neonates, they can be involved. And neonates tend to have a more inflammatory sort of presentation with nodules. And there's an irritable neonate who has a lot of itch, but he cannot itch. And superficial super infections are also common. So when a mite is seen on QH examination, the diagnosis is confirmed and the neonate is treated with crotameton. And application of a scalp is also advised. Moving on to the next group of neonatal pathological conditions, the disorders which are because of transplacental transfer of maternal antibodies, like neonatal lupus erythematosus, neonatal pemphigus vulgaris, neonatal pemphigoid, and malignant melanoma, which we'll only be talking about neonatal lupus erythematosus. So it is a rare syndrome, and it can present with transient skin lesions, which resemble subcutaneous lupus erythematosus. There can be congenital heart block, and there are transplacental passage of maternal autoantibodies to Rho SSA or La SSB. So commonly Rho La antibodies are present. The clinical features are that these infants have skin lesions and cardiac lesions. Approximately 10% have both skin and cardiac involvement. 90% of the infants will only have skin lesions in the form of these macular, slightly elevated erythematous annular lesions. They're present on the eyes, and this spectacle-like distribution is described, and also known as this distribution is also known as raccoon, resembling raccoon eyes. When systemic involvement is there, cardiac involvement is the commonest in up to 50% of cases. These lesions, though skin lesions require no treatment, but sun protection is advised. When there is fetal bradycardia or there are signs of heart failure, high-dose systemic steroids are also indicated. Moving on to another group of common cutaneous pathological conditions seen are eczematous group of disorders, in which there are perianal dermatitis, primary irritant napkin dermatitis, infant seborrheic dermatitis, and atopic dermatitis. So this is perianal dermatitis of newborn. This is very commonly seen it can be seen in up to 5 to 20% of neonates, and erythema is there in mild cases, and in a more severe involvement, it can extend to around 4 centimeter or more. And when it is severe, the skin can be edematous and superficially eroded. The treatment is limited to giving attention to hygiene. Then talking about diaper dermatitis, diaper dermatitis is a very general and a broad term, and it is conceptually divided into 3 categories: the disorders that occur because of wearing of diapers, the rashes that though occur elsewhere in the body but are exaggerated in the groin area due to wearing of diaper, which has an irritating effect, and then rashes that appear in diaper area irrespective of diaper use. So this is primary irritant napkin dermatitis. So it tends to involve the convex areas of the groins, because these areas are in close contact with the diaper. So buttocks, genitalia, lower abdomen, pubic area, and upper thighs that are in close contact with diaper are affected, and the deep part of the groin flexures are generally spared. Treatment required ABC. So air is that diaper should be left open whenever the child sleeps. B is barrier ointments like zinc oxide paste, petrolatum should be applied, and other bland unmedicated preparations. Baby powder is not indicated. In fact, it adds on to the infection. Cleansing, and C is cleansing and anti-candidal treatment. D is disposable diapers should be used more than cloth diapers, and they should be changed as frequent as possible after the soiling. And E is education of parents and caregivers. Specific therapy is in case there is intense erythema, topical corticosteroids which are mild, like 1% hydrocortisone can be given, and anti-candidal agents are used to avoid and treat secondary infection with Candida albicans. So this is infantile. Moving on to infantile seborrheic dermatitis. It tends to appear between 2nd to 6th month of life. It can involve scalp and face. When scalp is involved, it tends to involve vortex in the frontal areas, and in the face, it tends to involve forehead, eyebrows, eyelids, and nasolabial folds. Moving on to atopic dermatitis. Over here, though commonly perceived that it tends to it should start from napkin area. That is the area that is spared in atopic dermatitis, and the lesions usually in atopic dermatitis are seen on the face. And pruritus is common and more severe than seborrheic dermatitis, but it may not be evident in early neonatal period or infancy. Acute lesions tend to present with poorly demarcated erythematous, scaly, V-pick crusted presentation. Moving on to disorders of subcutaneous fats. These are starting with cold paniculitis. It is a distant form of paniculitis which is provoked by cold exposure. So when the neonate is exposed to extremely cold air, or when ice bags are applied on the skin, cold paniculitis results, and it presents as indurated warm red subcutaneous plaques and nodules within hours of the inciting cold exposure, and they tend to generally involve cheeks of the infants. But the good thing is that it requires no treatment and it tends to resolve on its own. Neonatal cold injury is another pathological condition that one should know about. It is because of the low environmental temperature. When the small for gestational age baby is exposed to low environmental temperature, the neonatal cold injury can present therein as intense erythema or cyanosis of face and extremities. There is firm pitting edema beginning at the extremities, which spreads centrally, and it becomes progressively more indurated in proportion of cases. It is generally, it needs to be differentiated from scleroma neonatorum, and the healthy state of the neonate, the pitting nature, and history of cold exposure and low rectal temperature can help in that. Moving on to subcutaneous fat necrosis of newborn, it is uncommon transient disorder in which there are focal areas of fat necrosis, and the underlying etiology is believed to be hypoxia, hypercalcemia, protease inhibitor deficiency in few cases. So this presents as nodular thickening of shoulders, back, cheeks, and thighs and arms. And these lesions, they're single or multiple, rounded or oval, and they are of variable size. So infants who have subcutaneous fat necrosis need to get their serum calcium measured on follow-up. Generally, again, no treatment is required. And in case serum calcium comes out to be raised, then furosemide dietary restriction of calcium and vitamin D is indicated. Scleroma neonatorum, this is rare, but it is a serious disorder, and it occurs over an underlying illness and tends to involve prematurity and small for date babies. And babies present with they're severely ill, and the lesions are having a woody induration. They can be present on buttocks, thighs, or calves. They spread very rapidly, and they involve the entire skin. The prognosis is poor in this disorder, and treatment is primarily of that underlying disease. So moving on to the next group of pathological conditions in neonate, congenital ichthyosiform erythroderma, starting with non-bullous ichthyosiform erythroderma. So in this, the 90% of patients, they present as colloidal baby. So this is the colloidal baby. So there's this, in colloidal baby, there is a glistening membrane that envelops the neonate, and it can produce ectropion, lip eversion, and nasal obstruction. So this is colloidal baby. When it desquamates, when the entire colloidal membrane desquamates, the patient present like this. The clinical presentation is like this in childhood, and this is non-bullous ichthyosiform erythroderma. Another ichthyosis that can be seen is babies who are born with colloidal membrane. So here there is colloidal membrane, and later on, when the colloidal membrane is shed, there is generalized ichthyosis with large, thick, dark brown, firmly adherent plate-like scales with underlying erythema. And these scales, they split and they cause painful fissures, as can be seen in this image. Another deadly pathological condition is harlequin ichthyosis. Here, the newborn is encased in a rigid, taut, yellow-brown, adherent, thick hyperkeratotic covering. So this is that thick hyperkeratotic covering. It splits in between at places, and the other findings can be associated are microcephaly. There can be ectropion, conjunctival edema, eclabium. Nose and external ears can be tethered, and it has a high mortality because of respiratory difficulty. So the next ichthyosis that can be seen is bullous ichthyosiform erythroderma, in which there are flaccid blisters, peeling of skin, and superficial erosions at the site of trauma. And these blistering, it tends to decrease as the child grows, but in place of that, the child develops gray waxy scaling. Moving on to the last group of disorders, they are inherited disorders, and in which incontinentia pigmenti is a rare X-linked dominant hereditary disorder, and the patient is a female child who presents with vesicular varicose pigmented cutaneous lesions and systemic involvement can be in the form of development defects of eye, teeth, and CNS system. The skin lesions are often present at birth, and they usually develop before the end of first week and rarely appear after 2 months. So the neonatal period is the time when these lesions present. There are 4 clinical stages that can be seen. Stage 1 is inflammatory macules, papules, vesicles, and pustules. Stage 2 is hyperkeratotic and varicose lesions. Stage 3 is the gray-brown pigmentation, and last stage is atrophic hyperpigmented bands or streaks are seen. So this has vesicles, that is the stage 1, and these are the hyperkeratotic varicose lesions. So combination of bulla with linear, nodular, or warty lesions in a female infant is pathognomonic. Usually no treatment is required except for the control of secondary infection, but eye examination is mandatory. Dental examination is indicated in early infantile period, and in case the child has neurological features, the child should be seen by a neurologist. Epidermolysis bullosa are a group of genetically determined skin fragility disorders which are characterized by blistering of the skin and mucosa following mild mechanical trauma. The various subtypes are EB simplex, junctional, and dystrophic. So simplex is the most mild type where there's an intraepidermal blister, and the remaining 2 can have more serious manifestations. This is the last slide, and the other pathological conditions that can be seen are because of complications of medical procedures performed on the fetus and neonate. So they involve scarring following antenatal procedures, scarring acquired due to procedures during delivery, that is caput hematoma and caput succedaneum, and Sir talked about it in the first presentation. Then there can be complications of phototherapy which can present as erythematous macular rash or darkening of the treated skin. There can be few phototoxic reactions to certain drugs like furosemide or methylene blue. There can be bronze baby syndrome. Again, this is because of the phototherapy induced discoloration of skin. There can be bullous and purpuric eruptions resulting from transient porphyrinemia and cutaneous necrosis following extravasation of intravenous medications. Thank you so much.
Thank you so much, ma'am. It is very exhausting list to cover within 15 to 20 minutes the pathological skin changes in a newborn. But whenever in doubt, please seek help. It's a message you get. So we please, and we cannot treat newborn baby at home or teleconsultations. So when needed, please always seek help, and our dermatologists will be able to clear your doubts regarding your skin changes, whether it is physiological or pathological. Thank you so much, ma'am. We will have questions at the end of it. I invite Dr. Darwin, sir. Sir has MS. Sir has done his MS from AIIMS Delhi and DNB and FACS. He is associate professor of otorhinolaryngology, head and neck surgery, and AIIMS Bilaspur, Himachal Pradesh. He has completed his UG from IGMC Shimla and PG from AIIMS Delhi. He has done his senior residency from PGI Chandigarh. He has worked as assistant associate professor in AIIMS Jodhpur before coming here, and he has published many articles in national and international journals, written book chapters and PG entrance books. He has presented many papers in national and international conferences. He has organized head and neck cadaveric workshop and national conferences. He has also invited faculty at national conferences. He has been quiz master for more than 6 national conferences. He is associate editor of the Journal of Otolaryngology and ENT Research. His areas of interest are head and neck surgery and skull base surgery and pediatric otolaryngology. I invite sir to talk on common hearing disorders in newborn and how to screen for them. That is very, very important. And when to send the baby to a ENT specialist. Please, sir.
Thank you, Dr. Nalin. Good morning, delegates and dear students. So, thank you very much, Dr. Nalini, for giving me this opportunity to present this presentation. In fact, this presentation has forced me to read also because we are not updated for past 2 years. So, yes, these kind of lectures are motivation for us as well as we get opportunity to teach. So, topic for today is causes of neonatal hearing loss as well as neonatal screening, how to proceed. So why this lecture is important for everyone is, remember, this is WHO data and whatever studies we have done, we have found that till age of 18 years affects nearly 1 out of every 5 children. That means this is a major problem. And if you don't diagnose this hearing, it has got detrimental effect on speech, language, developmental, educational, and cognitive behavior of a child. So yes, this is very, very important. With the advent of newborn screening, this is beneficial. So average age at which we are able to diagnose and hearing loss has been confirmed. What is the advantage of this hearing program is, yes, diagnosis of 24 to 30 months has been reduced to 3 months. So see how much is the difference. If you diagnose at 30 months, here you are able to diagnose even at 3 months. Means message goes is you should screen each and every child wherever delivery is there. Now, not only by neonatal screening program, but yes, mother. I always believe that mother is the biggest screener. Because response of a child can better be assessed by a mother. Yes, it is difficult in the newborn period. Lecture is on newborns, but yes, the neonates, even in childhood period also, sort of behavior observation audiometry can be done by mother. So it is not always audiologist or ENT surgeon. Mother can always, mother is the best doctor of a child. Now, what is the importance of neonatal screening? Remember, as I have already told you, that prevalence is approximately 0.5 to 5 in every 1,000 infants. And yes, WHO says half of these cases of neonatal hearing loss can be avoided just by, can be diagnosed by early neonatal screening. So this is very, very important. We should be going for this program. In the beginning, let's come to what are causes of neonatal hearing loss. Any guesses? What are important causes for hearing loss? So remember, you can divide very easy. You can divide 50% as environmental cause, 50% as genetic cause. In genetic, go for syndromic, non-syndromic. In that way, it will be easy to remember. Now, if you see environmental cause, what our MBBS doctors, whenever they go to internship in obs and gynae department, they take a long history of infections, any history of fever. So yes, that maternal fever is very important. These are the leading causes in front of you: cytomegala, meningitis, Bella. Okay, and in fact, when child is born, so you must have seen hypoxia at birth, bilirubin high. See, you have seen in previous lecture. So hypoxia, hyperbilirubinemia. So these are some of important causes, or meningitis with high grade fever. So basically what happens, all these causes are going to cause ischemic insult to labyrinth. Clear? And sometimes, during meningitis, what happens is labyrinthitis significans. Okay? So indirectly, for our MBBS students, it is going to damage labyrinth. So in genetic causes, yes, I have told you syndromic babies and non-syndromic babies. So this is important for genetic testing also. Should look for all those anomalies. Now you must have seen Pierre-Robinson syndrome, Todd syndrome, Standard syndrome, Waardenburg syndrome. So we should be looking at ear. Then this is the reason that next lecture is about ophthalmologic findings also, which are very important. This is the reason that our neonatologist is going to send all these patients to ENT, opthal, and all other different branches. Now, these are important causes which I have told you. How you can remember it also is that whenever we diagnose these patients, see, we have to divide them into genetic causes, suspected genetic causes, and just see here, genetic causes, suspected genetic causes, and third group you can divide into structural anomalies. So syndromic babies, you know, I have told you various syndrome. Non-syndromic babies, there are certain gene mutations, like connexins you must have heard. So there are certain gene mutations. And what about structural anomalies? For example, some patient has got enlarged vestibular aqueduct syndrome. Okay, you must have heard about Mondele's dysplasia. Here, rather than 2.5 times of a cochlea, we have 0.5 times of a cochlea. So all these structural anomalies are also important, and this is the reason it is written as CT or MRI imaging, because this is a diagnostic protocol. So purpose of putting this like this, please you remember, these causes can be divided like this to make you easier. Now, despite etiological evaluation, you will be surprised that approximately, if you say 25 to 50% of cases, we are not able to find any etiology. No etiology is found. We do every workup. Dr. Nalini will be doing so many investigation, metabolic screening, gene mutation, genetic testing, very costly investigation at times. But in 55 to 50% of cases, no etiology is found. These are the important risk factors. Pre-ischemic assault to child, anorexia, then increased bilirubin levels. Prematurity is itself a risk factor. Okay? The more important thing I have seen is toxicity in childhood. So remember, we as a ENT surgeon are very afraid of gentamicin, picasin. These are the toxic drugs. Clear? So this is my request also, that whenever we start these antibiotics, we should be getting some investigation prior to starting these toxic drugs also, and stay at neonatal ICU. So obviously, when patient is put there, some sepsis may be there, and we start some ototoxic drugs. So yes, whenever we diagnose, remember, we can do hearing rehabilitation. There is an option, so many options, supplemented by hearing aids and cochlear implantation. So the purpose of putting this picture is again to tell you that there are so many gene mutations which can be done at advanced diagnostic centers. Well, these are few guidelines where in neonatology period, patient may be normal hearing, but there are some risk factors here which can be for hearing loss. So these are NEGM guidelines. So I will be sharing this presentation. You can also read later. Yes, the important crux from this particular slide is you should be very particular in asking any maternal history. If there is any history of hearing loss, you should be asking any. You should see syndromes also, which I have told you. Okay? Any history of birth trauma, forceps use. Okay, that is also important. Here, nowadays, we have seen so many children or neonates developing otitis media with diffusion or acute suppurative otitis media, which are very important causes for initially conductive hearing loss, later on sensorineural hearing loss. Okay. Then, why there is a need for the screening? Now you have already, I have repeated 3-4 times that 5 to 6 such children out of 1,000 children are born deaf in India. So yes, it makes an absolute indication to screen. And results are always better if you identify disease earlier. Again, this is very important, and this message should go to our nursing staff, whosoever is involved in delivery of these patients. Screening should be in hospital premises before first discharge. That message should go. And if at all we have missed, at least 4 to 6 weeks is a critical period. This is universal neonatal screening. So even if you see that child is normal, we have to inform it by doing some investigation, which I would be talking. And remember, if it is not identified between 1 to 3 years of age, it has got disastrous consequences. Why? Because for our MBBS students, let me tell you, you just remember that this pituitary area is occupied by all other notorious areas. You think that there is some space which is empty, and now so many other things they have occupied this space. So what will happen? In brain, there is no space which is useless. So this auditory area will be occupied by all other notorious areas, and after 5 to 6 years, even if you do some hearing rehabilitation, child is not going to be benefited. Okay, so best age is before 5 to 6 years. Now, what are main objectives? Objective is obviously early detection, intervention, and disability prevention. So the first investigation here, and the two investigations are most important. First is autoplastic emission, and second is auditory brainstem response automated. Clear? So what are these investigations? Autoplastic emissions. So autoplastic emissions are basically, this is activity generated by outer hair cells. You ever heard of inner hair cells and outer hair cells? Those who are attending online, we have few MBBS students also. I think we have to go with them also. So outer hair cells and inner hair cells. So basically, what is there is this is a sort of machine. So it is just a mobile based system. You can see very easy. It has got one earplug, earphone. So earphone would be inserted into all of a baby. Only thing is absolute middle ear seal is required. Sound should not leak. Why? Because one sound will be going into patient ear. There is a microphone which will pick up the hair cells sound generation. Yeah? So what will happen? There is a waveform generation, right? And this waveform can be read by even paramedical staff also, and by nursing officer, people also. So very easy. This investigation hardly takes 30 seconds. This is the reason this is the most investigation for a neonatal screening. So this is a machine, not very costly machine. This is available at a cost of 3 to 4 lakh rupees. Very useful. So how interpretation is being made? Whenever there is a waveform generation, then whenever there is a positive response generation, machine will automatically show pass. And whenever there is no waveform generation or no bars formation, response will be fail. So I said pass or fail. But the problem was that whenever this investigation was in use, whenever we write child has failed, so suddenly anxiety is there कि अभी तो बच्चा नहीं हुआ है पहले ही fail हो रहा है. So lot of anxiety on behalf of this were there. So it was, we should avoid this word writing fail. Better word is refer. Okay, refer to secondary investigation or refer to ENT surgeon. Why? Because most reason for negative autoplastic emission is ear wax in our setup. Clear? So autoplastic emission, I told you interpretation is pass or refer. So this is the machine you can see. So this is how this ear plug is inserted into external auditory canal. Because it is absolute seal is to be achieved. This is a mobile based system. Very easily can be done by even paramedical staff. Okay. Now, what are the advantages? I told you this is a very cost-effective investigation, very fast, done within 30 seconds. Minimal training is required. This is a very small and portable device. Yes, it does not test beyond the cochlea. So that is a problem. I told you, check outer hair cell activity only. Coming to next important investigation, which is auditory brainstem response. So remember what is the protocol? Protocol is do first autoplastic emission, child is failing or coming refer, then go to ENT surgeon, refer this patient to ENT surgeon to rule out any wax-like disease entity, and repeat this autoplastic emission after 4 to 6 weeks. And if again autoplastic emission is refer, then refer this patient for auditory brainstem response. So, what is the prerequisite for ABR, automated brainstem response? To negative autoplastic emission, right? And why we are avoiding? We can directly refer to audiologist for auditory brainstem response in the beginning. The problem is, in auditory brainstem response, this is a very cumbersome investigation. You are able to see so many surface electrodes. Here, sedation is also required. It has to be calm. So the problem is challenge for our audiologist. So what is the challenge for our audiologist is sedation. Clear? So baby has to be calm. So sedation is required, and second is it is time-consuming investigation. Let me tell you, even a good audiologist is able to do less than 10 betas in a day. So if our audiologist has done 5 to 6 betas in a day, that means they are working very good. Okay, because it takes around 30 minutes to 45 minutes for beta. So this is the reason. First investigation is autocaustic emission. Referred, go to auditory brainstem response. Okay, automated ABR. So these are surface electrodes. This is how it is set. This is the waveform how it is being generated. Basically, what is the difference? In autocaustic emission, you are checking upper hair cell activity. In auditory brainstem response, you are checking integrity of auditory pathway. So by these surface electrodes, you are going to check brainstem activity. You record brainstem activity for first 10 milliseconds. Okay. So these are waveform. I'm not going into detail, but yes, there are some waves. There are 7 waves. The most important wave for us is wave 5. The largest wave for you, wave 5. Now, what is the importance of this ABR? Yes, this is most robust than autocaustic emission. We are testing at a brainstem level, but the disadvantage is this is a costly investigation. One Vera machine is costing around 6 to 7 lakh rupees, and more training is required in consuming investigation. So these are the disadvantages. So yes, if we have to choose, go with autocaustic emission first and then ABR. Now, what are operational challenges? Now, this is a very good study which has evaluated our national program for deafness. So what is this program? We always say we have to do neonatal screening, okay, before 3 days, before baby is discharged. So this study has critically evaluated this national program. What are operational challenges? You can see the problem is that in India, 15 to 20% of the deliveries are non-institutional, remaining 30 to 40 at PSCs, and remaining 30% as community health center. So problem is in community health center, in health center, and at home, there is no screening devices. And you will be surprised to know that many times in our medical colleges also, there are no devices for screening. So this is the reason that program is failing. So this is the first challenge. So only 20 to 30% of the newborns are delivered at district hospitals or tertiary medical colleges. That is the biggest challenge. Another is workforce shortage. Now, this is a very bitter truth that most of our audiologists, if you see, these are on contractual post. Clear? Low salary. So there is a shortage of audiologists on one side, and second, these are on contract basis, low financial these status. So this is another challenge. They leave job. So no fixed staff is there. And this is a very important, let me tell you. So skilled labor is missing. Third is we need to have soundproof environment, which is in fact costly. We need to have sedation. Okay, so sometimes anesthetist help or pediatrician help is also needed. Third is one Bera machine can perform, or one audiologist is able to perform less than 10 Beras in a day, okay, in working hours. So that is another challenge. So these are few challenges which has to be solved. So this is all about presentation today. So I have told you this autocaustic emission automated ABR. The take home message is that all causes of a hearing loss need to be identified as soon as possible. I told you before and is discharged. Second is we need to strengthen this national program of deafness because there are so many fallacies to talk practically, practical implications. Third is deafness can be rehabilitated. This message should not go. I've seen so many babies now. When we see in ENT OPD, 7 to 10-year babies are coming. Doctor has told us, or somebody has told us, that this will be cured after once baby is more than 6 years of age. Now, once baby is more than 6 years of age, you can do nothing. Okay, so the best time is now initial 6 months of age. And this is the reason. Always follow a rule of 1, 3, and 6. It means diagnose this patient. The first screening should be before 1 month. Then rehabilitate this child with some hearing aid 3 months of age. Think in terms of final rehabilitation before 6 months of age. So 136. You should follow this formula. So yes, this can be rehabilitated. Rehabilitated how? By hearing aids, implants, by some middle ear implants also. And this is a picture of cochlear implant, which is a very effective tool for rehabilitation. So thank you very much, Dr. Malini. I have provided some idea to our MBBS students, at least now they know how to screen these babies. Thank you very much.
Thank you so much, sir. Thank you so much, sir. Now I call upon Dr. Vipendra. He is Assistant Professor of Ophthalmology in AIIMS Bilaspur, Himachal Pradesh. He has done his UG from IGMC Shimla, PG from AIIMS Delhi. He has done his senior residency from RP, Dr. Rajendra Center for Ophthalmic Sciences, Delhi. He has subspecialty training in pediatric ophthalmology and oculoplasty, AIIMS Delhi. He has also a subspecialty certificate from pediatric ophthalmology from International College in Ophthalmology. He has 45 publications in PubMed Index journals. He is an editorial board member of Springer Nature, Ophthalmology and Therapy. Areas of interest is pediatric ophthalmology. We call upon Dr. Nirpendra talking about ophthalmological conditions with special emphasis on retinopathy of prematurity. Yes, sir.
Good morning to everyone. The outside, I would like to thank Dr. Nelly for organizing this CME and inviting me for this presentation. We're talking about common ophthalmic conditions in newborns and also ROP screening. So I've tried to keep this presentation least ophthalmology heavy as possible. So screening eye exam neonates is essential to rule out any structural anomaly that might be present. We should also observe neonates' visual behavior. Distant direct ophthalmoscopy examination to look for duplex. This is very important. I'll be talking about it in the later slides. So what are the red flag signs we should look for? We should look for leukoperia. Leukoperia is also known as the whitish reflex. Here we can see in this patient there is a whitish reflex in one eye. So this is the obvious sign we should look for while examining a newborn. So there are many differential diagnoses, important ones being cataract, retinoblastoma, psoriasis, retinopathy of prematurity, about which we'll be talking about in the later period. Then any kind of redness of eye, any kind of pill and discharge which might be present, also for any kind of this growth which we can see. So this is a child with a whitish reflex observed in both the eyes. You can see here, both the eyes he is having white reflex. This child was having cataract. So such a patient we should go to the ophthalmologist as early as possible. This is another patient. We are seeing a whitish reflex in the left eye. Further evaluation, who was found to be having retinoblastoma. So this is also another obvious case. Then we have this patient, this child, who is having these large eyeballs. You can see here, and there is a coloration, bluish coloration of the sclera because of stretching of the cornea. So this is due to congenital glaucoma, wherein the IOP of the child has gone up because of which there is a stretching of the eyeball and other structures. So this leads to blindness and it's pretty much curable if detected at an early stage. So this is another child having swollen eyelids. There's a yellowish discharge which is present over here. So this patient is having a pulmonary which is also very important with the newborns. Another, wherever we find redness or discharge, we have to consult a ophthalmologist. So this here we can see microphthalmos and ophthalmos. These are structural abnormalities which might be seen. And ophthalmos means there is absence of eye. We can see here there is an empty socket which is present here. In the another clinical picture, we can see that there is a shrinking of the eyeball. One eye is normal and another is small. So there might be congenital glaucoma which might be present. You can see here there is an absence of skin in the upper eyelid. So what happens in these patients? There will be constant exposure to the external atmosphere, leading to damage to the cornea and further leads to damage the vision. So such patients you should always just examine and then refer. So these were few abnormalities which we see. We talking about in detail about retinopathy or prematurity screening guidelines. So ROP or retinopathy of prematurity is a disorder of developing retinal blood vessels in the premature and preterm infant retina. The key pathology here is retinal neovascularization. This may regress completely or leave sequelae, mild myopia to bilateral blindness. This is a very important disease in newborn, essentially in the preterm infants. So here we can see there is a normal retina in the left side. We can see the right side for you. So this is the normal retina, and in the another diagram you can see there is a lot of bleeds which is present, a lot of new vessels which are present, bands. This is a patient having retinopathy of prematurity. So the main causes of this disease is prematurity. So there are various zones in which this disease can be present. The central zone is zone 1, zone 2 and zone 3. So the central part of the eye is the part which is involved with the vision mostly. So the zone 1 is most dangerous, zone 2 and then zone 3. So our treatment strategy also depends on whether the patient is having zone 1, zone 2 or zone 3. So why is screening so important? So screening is important because incidence of ROP in India about 20 to 50% in low birth weight babies, and 8.7% of newborns in India are less than 2,000 grams, which implies almost 2 million newborns at risk. So you can see here it's a significantly large figure. So that's why this screening becomes all the more important. So there are some questions for us. Which neonates should be screened for IOP? When should screening be done? Frequently should the infants be screened? When is the screening complete? When and how should the examination be done? When is treatment of IOP indicated? So we'll be discussing these in further slides. So these are the current guidelines by the Government of India to Bral Swasthya Karyakram, the ongoing program which is going on. So as per them, any child born less than 34 weeks of gestation age, that weight less than 2,000 grams, having a child born at 34 to 36 weeks having any other risk factor like cardiopulmonary respiratory support, oxygen requirement, blood transfusion, sepsis, apnea, exchange transfusion, poor postnatal gain. So these all children are risk. These all infants are at risk of developing this retinopathy or prematurity. So these should be screened. And first screening is weeks or 32 weeks post menstrual age in infants more than 28 weeks, 2 to 3 weeks in infants less than 28 weeks or less than 1200 grams of birth weight. So these are national neonatal screening guidelines. This differs only in the birth weight as well similar. So these are guidelines from American Academy of Pediatrics. We usually do not follow them in our setup because we are from Western population. So how and where to screen. So this is a photograph showing the screening of the retinopathy prematurity. This is the baby here. We are using an indirect ophthalmoscope to see the retina of the patient. Okay. So this is a screen where this is a RETCam machine where we are just clicking the images and saving and looking for the follow-ups, how the child is behaving. So this is the lens through which we are seeing. So basically, preferably we should screen in the NICU setting. And baby should be swaddled and fed 1 hour prior to examination. Fluid dilation should be done. Phenylephrine 2.5% and tropicamide 0.5% 2 to 3 times. 10 minutes apart should be instilled. Examination is done under topical anesthesia using indirect ophthalmoscopy, the dancing lenses, and scleral depressor. So once you will be coming to the clinics, then you will be seeing all these devices. Ophthalmoscopy, you will be learning these procedures yourself also. Right. This is a screening form in which we usually add the details of the RFP screening process. So we mentioned the stage of the disease, we mentioned which zone is it present in, and whether it is a leprous disease. This is beyond the scope of this talk. So screening interval depends on the zone involved and the stage of the disease. So more advanced is the stage, more frequent would be the screening, and less is the advancement, then less screening interval would be there. And when to treat, this is also as per the staging and the zone of the disease. So termination of screening is done then at the time of post-menstrual age reaches 45 weeks. There is no pre-threshold of birth therapy. So this is beyond the scope of the talk right now. I won't be going into the details. So nowadays, everything is being done in a digital manner. There's a digital revolution. So now new gadgets are there which enable us to not only see the retina, but also to record the findings in a photographic manner. Also, we can do a teleconsultation. So now trained physicians won't be present everywhere. Supposedly a patient, a person is sitting in the PSC. Just take the photographs and he can refer to the senior colleagues or at the tertiary centers and take advice from them. So this is a wide field imaging system and even non-ophthalmologists can do this. Okay. Only setback is the cost of this machine. This is the RETCam. It costs around 70 to 80 lakh, maybe 1 CR. This is the only setback. This is the machine which is present. Nowadays, these new devices are coming up which are quite cost effective. This is a 3 Netra for a screening device. You just use this device and you can see the entire retina picture in a single go. This is very portable and lightweight and 1/6 cost. So probably in future, as the technology becomes more accessible, so these devices would go down. Early screening is also important because it comes the relative scarcity of ophthalmologists in remote locations. So this was a program run by Stanford University, network diagnosis of retinopathy of prematurity. Screened 160 infants with RETCAN 2, and sensitivity was around 800% and specificity of around 99.4%. So this is specific and sensitive to detect the ROP. So Kid ROP program is being run by, it's an initiative being done in Karnataka. It's Karnataka Internet Assisted Diagnosis of ROP. So they follow a triple T strategy. So tele-ophthalmology using mobile RETCAM shuttle, human training ophthalmologist in the peripheral area, talking to pediatricians, neonatologists, and gynecologists about this disease by holding CMEs workshops like we are holding here. So CMEs are workshops in the peripheral centers, which involves pediatricians, gynecologists, neonatologists, so that no child is missed. So out here, even in our OPD, we have seen many children coming up with late presentation. So at that time, thing is done and dusted. You come with 5 ROP, stage 5 ROP, and nothing you can do or nothing anybody can do to them, to treat them. So there is a delay in the diagnosis, which is leading to the loss of the sight. And mostly these are the bilateral blindness cases. So if such programs are run and such CMAs are being done, more and more healthcare workers are educated, then we can bring down the cases of the blindness caused by this disease. Early diagnosis is the key here. So we have covered this. So in Karnataka, what they are doing, what they have done, they have published this thing. They had covered around 1,600 babies. They have 6 districts, 300-kilometer radius, 6 ICUs. They use it at Camp Shuttle, and there's again high sensitivity and specificity. So we can see here a large area they have covered using the digital means. So to conclude, newborn eye screening can be helpful in identification of serious eye disease. Referral to treating ophthalmologist should be done wherever needed. So this is the dictum. Always refer whenever you find some abnormality. Always refer to the treating physician, and this holds true for every specialty. So the dictum is when in doubt, shout and ask for help. Right. So this was all. Thank you so much.
Thank you so much, sir. Now we'll have question answer session. Online audiences. Offline audience. Any questions? No questions. Thank you so much, everyone, for being present here. So this last session was the first. So I thank our management, PD sir, Dean Academic sir, RMS sir, and IT team for supporting us, the participants, all the participants online and offline. Most important, the guest speakers. Thank you so much for making this event a wonderful one. Online participants, can you please switch on your camera so that we can take a click? Please, online audience. Thank you so much, everyone. We are closing the session. Thank you, everyone.